It's not to think that you have to be quote unquote strong, right? Going back to the idea of connecting, right? And so if you can even emotionally and empathically connect, that is extremely strong.
Well, yeah, the strength that I ascribe to, it's like, we'll get through this together. That kind of a strength. I know this is hard, but we will work at this together. And that this belief that we can do this, right? This is not impossible.
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arnaud, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area. Good morning, Dave.
Good morning, Andrew. How are you doing?
I'm good. We are on episode 51.
Wow.
And that's just 1 year of recording and 1 week missed.
Yeah.
We recorded over holidays, late night recordings. We've made it for a year.
Oh man, this is funny. This is like I went to that new Mario movie with the family on
nice.
Easter weekend, and
Yep.
one of the phrases in there was like, they were obviously making reference to something else, but it was funny because it hit home. It was like, the days are long, but the years are short.
Oh yeah.
And you know, when you have kids, and
Yep.
my oldest just turned 9 yesterday, so it was like, oh my God, 9 years, right? But in the day to day, it's like, so it's like this podcast. It's kind of the days are long, but the years are short. It's like, oh my God, we've been doing this for 51 episodes. This is, it seems like it flew by in some ways, and in other ways, it's like we've been, at this. We've been working at it, and yeah, so
Yeah. And it seems to be reaching people, I'm always surprised when I look at the statistics, the analytics of where our listens are coming from. We were just talking about this, but there's been a flurry of action from South America lately, from Southeast Asia, South Asia. Australia has always been very consistent, and a lot of from the southern United States as well. So it's been really cool to see where this is reaching, and we're getting some private messages, people just letting us know that the podcast has touched them in some way positively, in terms of being reminded of certain things, or even just like the educational piece of it, right? Understanding. We just had like 4 episodes on ASD, and just really understanding ASD now about a family member or themselves more than any other clinician has spent time discussing their diagnosis with them. So hey, if this message resonates with you, of course, we love to receive comments and messages, but even if we don't, and you're getting something out of this, this is why we do it. So thank you.
yeah, I think that has been one of the more like heartwarming, unexpected parts of this, right? Like being able to share this information and share our experience in a real personal way has, at least from the people that have talked to me about it, it's like it's been meaningful, and they'll share it with other people that they think it would resonate with. And really, at the end of the day, we're just chatting about stuff that we do at work, and the things that we know something about. We don't know everything, and we are very open to that. We are not trying to provide a comprehensive lecture on every topic, but we're touching on things that we just hope we can demystify some of the myths that are out there, the misinformation, or even just the destigmatizing and helping people not feel so isolated in whatever they're going through. And I think today's topic really fits that bill. So today we're going to be talking about suicide, and just a bit of a warning that, this is a difficult topic. And when we talk about, being touched by the podcast, this is a topic that has touched a lot of people in really difficult ways. So hopefully we'll be able to have a conversation about this difficult topic in a way that helps people, again, feel less alone and maybe have some direction in terms of some resources or some supports or even some ideas on how to respond to someone if they are, having thoughts of suicide, how to heal from possibly losing someone by suicide, and even some stats on this topic, and just kind of we'll probably start with some stats and some myths and then go into more of the other stuff further
Yeah.
down.
And I think more people than we think do have thoughts around death and end of life. And I must say, just in my own clinical experience, it comes in different forms in different ways. So I remember, for example, working in palliative care during my residency, and there was a rotation in palliative care. And, you know, obviously all the clinicians, hospital staff, they get worried when they hear somebody talk about death. But there's different thoughts around it, right? There can be thoughts around, I'm at a certain stage of my life. And so just inherently, this idea of death comes up. And what does that look like? What will that feel like? And sometimes that can get misinterpreted as, oh, someone is having suicidal thoughts. And
Hmm.
I remember very distinctly working with an elderly gentleman in the hospital, and he was like, you know what, I'm not suicidal. I'm just, I'm at a stage in my life where I am thinking about death, though. Right. But it was a more of an existential conversation about it. Right. Having said that, though, even private thoughts of ending one's life, not everybody is going to announce it. Right. But fleetingly, people may think about it.
For sure. And I think, this is a bit of a blessing and a curse. Like, we are a species that understands our mortality. We know
Hmm.
that we are going to die at some point, right? And that we won't be here anymore. And there's an entire type of therapy called existential psychotherapy by
Hmm.
Irvin Yalom. And I'm actually reading his book right now. It's a beast. It's a huge book, but the whole therapy is looking at that, the idea that we understand that we are going to die and how that can actually help us live better, right? And I think
Yeah.
with suicide, I mean, there's different views on this, but like one of the things that I've learned or that I've come to is like it's a premature death, right? And we have a hard time with premature deaths, right? Like, it's anyone who isn't at the end of their life cycle, right? It's
Hmm.
like, oh, why? Why would this happen?
Hmm.
And so again, the stats are high. Like, there is a lot of, I want to pull this up because I think, it's a bit shocking. And I want to say this with sensitivity because we also know from research that when there is like a popular someone who died by suicide in the media, it does kind of increase suicide rates. So there's been a sensitivity around not publicizing or talking about suicide.
Yeah.
But at the same time, we know that one of the biggest myths is that, asking someone if they're suicidal will make them more suicidal. And that is not the case, right? So
Yeah.
I think we
Yeah.
need to have this balance where we're talking about something in a certain way. And
Yeah.
again, we'll say this right off the hop. If you're looking for help, if you're needing help, if you're feeling like this, then reaching out and letting people know will be the best way to get that support and not, isolating and keeping it to yourself. So
Yeah. So please, if this episode, does trigger something within you and you're not feeling too well, and please do reach out, connect with someone, go to your nearest emergency room, dial 911 if you need to. And also, please note that, this episode is not a training module. It is not to train any parents, adults, educators to deal with this alone with your own children or child or family member or friend. This is not what this is intended to be. It is still, for educational purposes and for us to shed some light on this topic. So, yeah.
yeah, we'll probably keep saying this. Like,
Yeah.
there's a number in Canada right now, if you live in Canada, 988, that is designated for like a suicide hotline where people can call in specifically for that and get support, you know, in that moment. Actually,
Hmm.
that brings me back. Before I was even in my education to be a psychologist, I was volunteering and trying to get experience in the area. And one of my experiences was working on the distress line. And, that distress line essentially is for people calling in that are in distress. And one of those distresses is, thoughts of suicide or plans of suicide. So that, that has, I'll probably shed some of my experience from that throughout this podcast. But I think, I'm going to say this now and I'm going to keep saying this because we kind of bounce around a bit, but we want to make sure we hit the highlights. And one of the highlights is that, 99% of people are like 100% of the people that I spoke to on the phone that were in the midst of, being really close to ending their life by suicide. If you ask them, do you want to die or do you just want the pain to end? They want the pain to end. So if we can look at what is the emotional pain or what is
Yes.
this the stress that is, feels unbearable, we can focus on that, right?
Yep.
Most of the people are not like you were saying in palliative that are I've had a good life and I'm, okay with the fact that I am dying. This is someone that doesn't really want to die, but doesn't want to be in this amount of pain,
Yep.
typically. So,
Yep. The power of emotion, right? The emotional pain a lot of the time is just so overwhelming and overbearing that they feel trapped. And we'll get into this a lot more too. Just the experience of feeling trapped emotionally. And so, how about stats, Dave? If we pull out some stats, perhaps we start with that.
yeah, and again, you could probably get stats pretty readily on the internet in terms of where you're located. But here in Canada, some of the stats, like they're not going to be super current because it takes a while for these things to be, publicized. But so in Canada in 2023, over 4,700 suicides, right? And those were completed suicides. Those are people that have passed away by
Yeah.
suicide. And the attempts are far higher than that, right? And our population is what, 36 million, 37 million roughly? I don't have
Yeah.
the, yeah. So, and then if you look at specific age groups, one of the more concerning age groups, the males between 15 and
Mm.
34,
Yeah.
you know, they account for 75% of the suicide deaths,
Yeah.
right? And so that is a high risk age group. And I think don't quote me on this, but it's like the second or third highest cause of death for that age group, right?
Yep.
So
Yep.
when we think of motor vehicle accidents or we think
Yes.
of cancer or we think of all these other like ways that people can pass away,
Yep.
oh my goodness, we are losing a lot of young men to
Yep.
this.
Yep.
And I'll also say the stats are a bit misleading because women actually attempt suicide at a pretty equal rate to men, but men tend to use more lethal means. So
Yeah.
the actual completion rate is a bit skewed. It doesn't mean that women aren't suffering just as much as men, right?
Yep.
But unfortunately, when men do something like that, it can end their life, right? And they don't come back from it.
Yep. So I think depending on where you look at the stats, I'm looking at it from Stats Canada, Statistics Canada, and they did mention that women attempt suicide 3 to 4 times more often. But interestingly, 75% of suicides involve men, successful suicides.
Yeah.
So to your point, in terms of the lethality of the means that are being used, men have a higher completion rate, which
Yeah.
is concerning. And I mentioned here with StatsCan as well, in Ontario anyway, so in the province of Ontario, 14% of high school students report having seriously contemplated suicide
Yeah.
in the past year
Well,
versus 4% for adults.
you said successful suicide, and I
Hmm.
think even the language around this, we're going to keep going back and forth, but
Yeah.
so yeah, I just that one throws me off because I'm like, I don't think that's a success, right? But
Success. Yeah. The word
it
success.
but it is a completion. It is,
Completion. Yeah.
yeah, like they
Yeah.
attempted something and whether it happened or not. But
Yes.
oh, we can get caught in this or even like a failed attempt, right? And it's like,
Yeah.
well, I don't think that's a failure, right? Like
Yeah.
and so the language around this is really important too. And I think you'll probably correct me and I'll probably correct you. And some of the language has
Yeah.
changed in the recent years in terms of, and you'll notice that I'm saying death by suicide or passed away by suicide, and I'm not
Yeah.
saying committed suicide, right? Like
Yeah.
that's an old term based on this, like, that suicide was a sin. And if someone committed a crime or committed a sin, that was,
Yeah.
and I think that language has actually made it harder for people to talk about suicide and the stigma around suicide.
Well, it's interesting, right? Because when I worked in a Catholic school board, that was one of the contentious pieces
Hmm.
about education with mental health,
Hmm.
suicidal ideation, especially high school mental health. And there was a huge thing around, do we even advocate for it? Do we provide education? Of course, the psychology department was like, well, you have to provide education. But depending on people's agendas and beliefs, it was like, no, you can't touch that topic. It's like, come on, we have to get with the times here. It's happening, right?
Yeah. Well, one of my earliest experiences with suicide was in junior high. And it was a student that was a couple of years older, but I went to a Catholic junior high. And most of the funerals that I attended to were at the Catholic Church. It was one of the biggest kind of, like, in terms of a venue that could accommodate a large amount of people. So you think
Hmm.
of a young person passing away, but then if they're not able to be, if they're not able to have a funeral at the Catholic Church,
Hmm.
right? Because it's not recognized as, or it's not, anyways, I don't want to get into all the details, but think of having a child who dies, and then the way that you have your community, your
Yeah.
supports are all connected to your church, and then the child isn't able to be buried or isn't able to have a funeral through the church. And then what does that mean? And then can we even talk about
Yeah.
it? I don't think, yeah, we couldn't really talk about it. We just knew that this person had passed away and that they were gone,
Yeah.
and I don't remember a lot of education or supports around making sense of it.
Yeah. I had no idea we were going to dive into religion.
Well, how can you not on this topic, right? Like, oh, death and dying and is so interconnected with religious
Faith.
beliefs and
Yeah.
faith. And
Yeah.
of course, how do we make sense of life? Like, these
Yes.
are so intertwined, and suicide is one that is, again, has been recognized as a sin in some approaches. And I think some of that has shifted and changed,
Yeah.
but there's still that it's wrong or bad. And if something is wrong or bad, how do we treat people or their family, right? Can
Yes.
really. So my heart goes out to the folks out there that have felt the brunt of the negative stigma to the way that someone they loved has passed away.
Well, even with that stigma, I mean, by now, if you've been listening to this podcast, you know that I work with children and teenagers a lot. And it's oftentimes, the teenagers will come with this topic. And, if parents get wind of it, you hear a lot of that negative stigma and shame. You have no clue how good you have it. And, I know that from the parents' perspective, they come from a place of positive intention.
Hmm.
Um, but without, you and I, we practice in this field. And so we know sometimes what to say and what not to say.
Hmm.
Right. But, certainly that is probably something that's going to be unhelpful, and this is why we do this podcast too, right? Is to let people know, like, in times of emergencies and, you know, difficult situations, what can we do?
I think if you love someone and you see them in pain, it is
Yeah.
hard. And if they mention
Yeah.
suicide or they mention they don't want to be here anymore, that can be absolutely terrifying. And
Yeah.
sometimes when we're afraid, when we're desperate, we say things and then we react in a certain way I think, out of desperation. And so
Yeah.
hopefully you might have some other approaches or some other phrases you might be able to lean on if you encounter this. Again, this isn't training on how to be, on the distress line and respond to people that are,
Yeah.
having suicidal ideation. This is about like if a loved one says, I don't want to be here anymore, you might have some different ideas on how to respond rather than some of the more unhelpful ways, like you said, of like, think about how good you have it, or let's think positive, and try to ignore it rather than
Hmm.
lean into it and be like, oh, where's that pain coming from? Right?
Yep. Yep.
Yeah.
The other piece I wanted to add about in terms of high school students and suicidal ideation and even behaviors, we have to keep in mind again, I always go back to the developing brain, with executive functioning still developing, sometimes having some difficulties thinking about certain consequences of their actions, sometimes being a little bit more impulsive, because again, that executive functioning is still developing, and so in the moment it just feels like the right thing to do, or like the thing that they need, right?
Yeah.
And so they act on it, versus sometimes with adulthood, if we do slow down, and we have the ability and the capacity to slow down a little bit, we don't act as quickly or as impulsively. Right.
Hmm.
So that's why sometimes you will see the rates of that younger population. You mentioned 15 to 34. I
Hmm.
wonder, if we could find a breakdown of even like 15 to 25-ish.
Yeah.
This is why sometimes you see that rate to be higher.
For sure. And we know like young men in particular are at
Hmm.
higher risk of, motor vehicle accidents and
Hmm.
like kind of that risk-taking
Yep.
behavior, right? So,
Yep.
you know, the stats don't even cover the amount of accidental
Yeah.
kind of deaths through risk-taking, whether it's even drug use or alcohol use or any kind of stuff that, again, that younger generation that might be, like you said, neurodevelopmentally at a higher risk for impulse, challenges and not being able to weigh out, long-term impacts of their decisions,
Yeah.
right? And so,
Yeah. I just
yeah,
looked here, Stats Canada. I just did a deeper dive. 29% among youth aged 15 to 19. So suicide accounted for by 29% of youth between 15 to 19, and 24% among young adults aged 20 to 24. And this was back in 2018.
yeah.
Yeah.
Well, and one of the stats that I don't have in front of me, and it's a long time since I came across it, so maybe it's not even, as accurate, but it really kind of, I've kept it with me very close that it's like most of the people that attempt and that survive report that they are glad that it did not
Hmm.
happen. And so
Hmm.
this idea that in the moment we might feel like we don't want to be here anymore. But like you said, as adults, we might be able to remind ourselves like this will pass, like things can
Yeah.
change. There are other options. But in
Yeah.
that moment, it just feels like it is the only answer. It is the only way out of the pain.
Yep.
And we know that if like this is why we form people, why we can admit people to the hospital against their own will and keep them there for like 72 hours, right? Doctors can do this, even psychologists can do this, where
Yep.
the rationale for that to take away everyone's like freedom or their rights, because we know that if we get them support and after 72 hours, they likely are going to be thinking differently and feeling differently, right?
Right. Yep. Yep. So the whole admission piece, it's keeping somebody safe,
Hmm.
right? Keeping somebody safe, providing immediate intervention
Hmm.
in hopes that, within, like you said, that 72 hours, they will feel a little bit different, hopefully on the more positive end,
Yeah.
right? But doesn't necessarily mean that there's no work to be done after that, right? So
So do you want to myth bust? Go through some of
yeah,
these.
let's myth bust. Where do you want to start? Because there's quite a few. There's quite a
Yeah.
few.
I think we are already mentioned the most important one that like
Yeah.
talking about it does not increase the risk of it. So
Yes.
do not be afraid that if someone is kind of alluding to it, if they're making comments about not being around anymore, that address it directly and just be like, are you thinking about suicide? Is this, and then having a direct conversation about it. But again, if you had no experience with this and no one's ever talked to you about it, it can be one of those taboo subjects that it's really scary and hard
It
to
is
talk
scary.
about. So even just
Yeah.
practicing a bit, like with
Yeah.
yourself and being like, how would the words even come out of my mouth? Like the word suicide can be like a bad word that is hard to say.
I'm gonna throw out there too, even with early career psychologists, trainees, it's a scary place to go with a client sometimes. I've done my fair share of supervision and I continue to, but when somebody brings that up, the clinician's heart might skip a beat or two, right? You may not see it, but definitely everybody perks up. And this is where experience comes into play and just really good training. So the idea of talking about it, not just for caregivers and partners and friends, but even sometimes within the therapy room, it can be uncomfortable.
Oh, for sure. I don't think there's I mean, I don't, maybe there are some, but very few psychologists, therapists, counselors are going to say that this is something they enjoy doing. Like it not only is terrifying that this person might act in a way that is going to hurt themselves, but it also like the liability side of it.
Hmm.
There's this like anxiety that comes with doing a suicide risk assessment and making sure that you've done everything professionally, right. Because
Hmm.
if something happens, people are going to have questions for you. And so there's two things that are happening. There's fear and worry for this person in front of you, and also a little bit of fear and worry for your own like well-being and your own professional ability to practice in this field. So I think that anxiety can all of a sudden derail things. And I mean, we're human, we're doing our best. I know even there's some, again, old research that I can't quote right now, but I think it's out there that one of the worst experiences that therapists have is a client suicide, that it is
Yeah.
one of the most difficult things, right? So we are not
Yeah.
immune to it. We have
Yeah.
more training and more experience and hopefully more supports, but we are not immune to the challenges that come with this.
Absolutely. Having said that, though, I think within the therapy room, this is where we do tackle it head on.
Mm,
Whereas, with someone who's not trained to do this, yeah, it's a very terrifying topic to be like, oh, what? I can talk about this head on.
mhm.
But what if, right? All the what ifs. What if I do talk about this and we open a can of worms and I don't know how to close it up? Is that going to put the person more at risk?
Yeah. Yeah.
Right.
So, okay, talking about it doesn't make it worse. We've already talked about like that people who attempt suicide just want to die. That is
Yep.
not true, right? It's like
Yep.
asking, where's the pain? And even I keep going to young men because that's kind of the population that I see a lot. And, financial stress.
Yep.
A lot of young men, they lose their job or
Yep.
they get into a bunch of debt, and
Yep.
that can just seem insurmountable. Or even gambling. There's a lot of like, more and more gambling issues with online
Hmm.
gambling, and people can get themselves in a lot of trouble and
Yep.
not say anything to anyone and then feel like the only way out is to not be around anymore.
Yep.
And so you might you might just be really curious about what feels impossible or what feels like you can't deal with anymore. And then
Yes.
being able to break that down, there usually is a way to deal with it, right?
Yep. Yep. The other piece that I've seen is drug abuse, drug use.
Hmm.
Oftentimes, if you think about this, at least from a theoretical perspective, why do some individuals turn to drugs, right? It might be to get away from a current situation, right? So if I'm in a euphoric state and I can get myself into a euphoric state, I don't need to be faced with whatever reality I have, right? And so, they turn to drugs and alcohol to leave their reality. But sometimes reality catches up and it's so painful, right? We go back to that idea of pain, right?
Yeah.
And so then the propensity to
Mhm.
to think of suicide is greater.
Well, yeah, I'd say like pain and shame. right?
Yep.
And so that cycle of like I've done something, I feel terrible about it, and it means I'm a bad person or it's my
Hmm.
own fault. Like I put myself in this situation. And so that shame stops us from reaching out. It stops us from talking to other people, right? And so being able to, whether it's gambling, drug use, porn addictions, all of those negatively stigmatized kind of behaviors are going to leave people more likely to feel like there's no other option, right? And so
Yep.
the message we want to give people is there is another option. There is a way out of this. There is a way to deal with things, even if it's hard,
Yep.
right? And that
Yep.
people love you and people care about you and they would rather you kind of sort through this than take that option of not being around. So,
Yep. Yep. Here's an interesting myth. People who talk about suicide just want attention. And that one is absolutely untrue, that statement. But interestingly, I have heard, again, caregivers,
mhm.
parents tell me that in a conversation that my son or daughter, I am sure nothing will happen. They've done this before and they just want the attention.
Yeah. Yeah, that is a common one. And so if you think about that as attention seeking, right? This is attention seeking. So how do you respond to someone who's just attention seeking? Well, you could ignore them because you don't
Mhm.
want to feed into it. You don't want it to continue, or you could, you could punish them or you could, give a negative kind of response to stop the attention seeking, right?
Yeah. You can make a patronizing response, right?
Yeah, it really minimizes what's going on, right?
Yes.
For the vast majority. Maybe there's some people that are, using lots of different ways to get attention, but even those people, it's like, well, everyone wants some attention. Maybe providing that attention is important. Like maybe for a lot of kids, they don't understand how to get attention and they're trying in many ways to get. So seeing it as a cry for help is usually a better way of
Hmm.
looking at it, right? It's
Hmm.
like they need help with something
Hmm.
and they're saying it. And for some people, it is something they do not want anyone to know. And it's
Yeah.
hard for them to even get the words out of their mouth. So
Yeah.
that's where I would start.
Yep. Often the cry for help. And if you think about the cry for help, it's requiring help to problem solve, right? When we go back to the idea of pain, or again, high school students, maybe something happened at school, with this, with social media, with popularity, all those things come up, and for many teenagers, these things are very important, right? But maybe they hit some sort of wall, some sort of challenge, and they just feel trapped. Right. So when we get this cry for help and you're thinking, well, no, no, they just want this attention,
Mhm.
right? Think about it differently. Think about it from the lens of a cry for help. What do they need help with? Why are they saying this?
Yeah, yeah. So leaning into where's the pain? What do
Mhm.
they need help with? And again, when we break it down like that, if I'm asking someone, if you weren't in this pain, would you still want to die? And they say no. And then we go, okay, well, what's causing the pain? Where's this pain coming from? And if it's loneliness or if it's fear or if it's, then we can generally come up with a plan to try to address that, right? And that might be with loved ones. It's just like, oh, what is stressing you out right now?
Yep. Another myth, suicide can always be predicted if people pay enough attention. And again, I think this is where I've heard from clients before. How did I not see this? How did I miss it?
Yeah, and this is one that we're not immune to either. Again, like we
Mhm.
have like research-based, suicide risks assessments, right? Where we're asking specific questions and then based on those responses, we're trying to gauge the likelihood, right? The level of risk. But even with all of that, there is oftentimes so many people after are just like, I should have known, I should have seen it. And I mean, I don't know. I'll throw this out at you, but you don't have to answer this, but have you lost patients, clients to suicide in your practice so far?
Not my practice. I remember years ago now. I mean, obviously my practice, yeah, we have had people come in and say that, they're suicidal and so on. But In terms of suicide itself, years ago, I was in my residency actually, and we had run a group at one of the services that I was a part of. It was a short-term group, maybe about 4 to 6 sessions. Only found out later, I think it was a few months later, that this individual had a murder suicide. Yeah. I won't get into any more details about that, but just for
No,
confidentiality's sake. But
for your own process, like
yeah,
after getting that news and did you have those what ifs or did I miss something or could I have done something? Like those are common reactions to that kind of.
I think it was the one that I had was like, did we miss something? Right? Did we miss something? And as I processed it through with my supervisor, I think the conclusion was, how there were no signs, right? Not
Mhm.
that we could see. And this is, remember, this was also a group. So this wasn't like individually asking a person in a private session, how are you feeling? And are there thoughts of suicide or homicidal ideations,
Mhm.
right? So this is more about brain injury and psychoeducation and stuff like that, right?
Yeah.
So it wasn't even going to be a particular topic that we would talk about, but there certainly weren't many signs. Like this person, if I remember correctly today, they participated, right? Came to
Mhm.
every session and participated, engaged, shook hands with everyone. Yeah, months later. Yeah, yeah.
Yeah. And I think a lot of times we're left without answers. Right.
Yes.
And
Yeah.
unless someone leaves a note, then possibly you have a little more better idea. But a lot of times people are just left without answers. And I know for myself, the couple of times that this has happened in my practice, I do question and I do, I can catch myself kind of ruminating on it and going back
Hmm.
to it and even thinking about talking about this today. Those experiences come right back and it's like, again, did I miss something? Could I have helped this person so that they
Yeah.
didn't do that? Right. And knowing that, like, I can't, there's no way of being able to do that. You can do your best, just
Hmm.
like family, a loved one. You can try your best, but unfortunately, we cannot control what other people do. Right. And we can do our best to see the signs and to be open and be welcoming to talk about hard things, but we cannot blame ourselves for things that other people have done, right?
You know what's really interesting as we're talking about this, and I know this might be a bit of a side note, but as clinicians, and this is just dawning on me right now, and I wonder if this is a trend amongst most clinicians, if not all, we always remember these significant events. Like, look, I was in residency. This is what, back in now 2012
Yeah.
when this happened. Like, we're in 2026. Right? I
Yeah.
have not forgotten about that. And it just still seems like yesterday. And I can probably sound off all the times at the school board where I had an emergency and had to call 911, or even in my own practice when I had to safety plan for certain clients. Like it never leaves you as a clinician.
No. No, and you know what? This actually brings up a thing that I've noticed, like in my practice, but also personally, the response to suicide,
Mm,
sometimes can be anger, right? And I think rather than feeling helpless, rather than feeling some of these other uglier feelings that I'm actually feeling right now, we
hmm.
can get kind of angry at the person and say, why did you do that? Or why would
Mm.
they do that? And that can be the conversation sometimes. And I think that actually prevents us from feeling some of those other feelings that are really hard to feel, right?
Yep. Yep.
So, like I said, not blaming yourself, but also not blaming them, right? Like, in some ways, when these things happen, we're like, we need to find someone to blame, or we need to, have a reason for this. And being careful with that, it's like people that go through with this are suffering, and people that are around them are generally trying to help, right?
Yeah.
And so there doesn't need to be a person to blame or something to blame.
Well, I think as humans, we're sort of hardwired to look for fault, right?
Hmm.
And so if something doesn't go according to plan or expectation, and something significant like suicide happens, the community starts to look for why, how, who,
Mhm.
right? Who can we put this on now?
Actually, a good book that I read a couple months ago that was I was looking for resources on this topic, and it's not I mean it's not the resource I was looking for, but the book called Life After Suicide by
Mm,
Jennifer Ashton, who was a very public figure and had her husband die by suicide, and her book really describes a lot of that, like people looking for answers, other people making assumptions about things and how difficult it can be. So as a you're not alone kind of book, I think this is a
mhm.
great
That's a
resource.
good one. Yeah. Yeah.
Okay, let's get back on track. Are we done with myths? I think looking at the time.
Yeah. I'm just going through there are many.
Yeah.
I think we've hit on the big ones. Oh, I guess here's one more, if I can throw this out there. If someone seems better suddenly, the risk is gone. And this was when we sort of picked up, I believe it was with Dr. Mark Nicol, because we did talk about suicidality and borderline personality disorder. And I think the question to Mark at that point in time was, have you ever seen, somebody sort of get their mood get elevated, but then they still follow through with the suicide attempt?
Well, actually, yeah, that it actually is very common. I remember this
Hmm.
from my training, like on the
Hmm.
distress line, and I think I actually saw this in some sitcom episode, maybe Degrassi High way back in the day. But that it is very confusing for people because they're like, no, they were smiling, they seemed more engaged in life, they were less depressed. But that is actually a common experience that when someone has made a decision that they're not going to be here anymore, and that can change their mood and actually change the way they interact with people. They might
Hmm.
even be saying goodbye to people in a way that you're like, oh, I should have saw that. I should have noticed the way they were like, almost like a final goodbye.
Yeah.
And so yeah, this is a confusing part, that there is the myth of like, well, they were doing better. They shouldn't have,
Yeah.
but they were doing better in a way because they knew they were getting out of the pain. They knew they were leaving.
Yeah.
And so,
Yeah.
yeah. So don't
Yeah.
take that as a, oh, well, they're not thinking of that anymore because look
Yeah.
at how happy they are. It's like, and again, if you miss it, you're human too, right? Like it's,
Yeah.
yeah.
And for this one, it sometimes is sort of like that momentary spike in their mood,
Hmm.
right? So it could have been like yesterday or 2 days ago, they were so down and so on. And then today, all of a sudden, like, oh, yeah, they seem to be doing great, way better, right? And so, perhaps we're not as vigilant and we think that the person's all good now, but it's still really important to monitor.
Yeah, and again, a lot of people are left with their last interaction with someone, right? If you are, a family member, or you are a friend, or you are someone who knew someone who passed by suicide, often that last interaction gets replayed over and over, and it's like, should I have known? Should I have seen something? Or why didn't I say something? Or like, and you can beat yourself up over and over
Yep.
again. But yeah, again, we
Yeah.
cannot, there's a lot of reasons for this. One of the other myths is that it's just mental health for why someone would, pass away by suicide or choose to do something, to self-harm. But there's a lot of reasons for it. It's complex and it's
Yes.
not as simple as one thing, right? So.
All right. So where do we move on from here, Dave?
Well, we're kind of touching on it as we're going along, but like the support that's needed. I actually remember there was, when I was doing the distress line, they also had a specific grief and bereavement course or support for people that have lost someone by suicide. And so it is a unique way to grieve or to process the loss that is not
Mhm.
common in, say, other ways that people pass away. So just recognizing that and looking for specific resources that are out there, or even groups, support groups that people have a common experience. And so, yeah, the why did this happen? This could I have stopped it? Those are common experiences that people are left with that they need to kind of come to terms with to be able to move on with their own life, right?
That's right. I'm just looking here. Like we've touched on the myths, we've touched on the statistics, and I'm just thinking, for the next part, it's like, so what can we learn from it? What can we do?
So, I mean, I was touching on what can we do after someone has passed, right?
Yeah.
And we're left with all those questions. But what can we do if we know someone that, kind of the do's and don'ts or the tips that might be helpful? I think that's where you're going.
Sort of. And again, this is not a training module for what you should do and you're the sole provider for this person and you have to be the one responsible. That is absolutely not our intention here. But I think from a clinical practice perspective, like again, working with so many youth and teenagers, parents, caregivers, educators, they're actually the first line of someone hearing of a person who is suicidal or harming themselves.
Hmm.
So I do think it is important to know, okay, in that moment, what do I need to do? Right? So many times I remember working at the school board. It's like right away, go tell principal, principal, gets the message up to the school board, and we're then scooted down to go and, quote unquote, fix things. But I think there's such a gap there in terms of, in the moment, what can we do to show the student or to show that person that I'm here for you as well, right? We need to connect right away.
Hmm.
Instead of waiting, 2 hours for someone to come down who you've never met before. So here's the
Yeah.
thing, right?
Yeah.
Like teachers, parents, principals, coaches, whoever, you establish a relationship with that person,
Yeah.
right? With that student. And I'm sorry, I'm using students here a lot just from my experience, but you've had an established relationship with that person. And so that's why they're coming to you.
Hmm.
And sometimes the problem we found was that you scoot someone down from the school board, they've never met you before, right? And now you're expecting them to just open up about everything.
Hmm.
Whereas they're way more comfortable opening up to the teacher.
Well, again, I think it triggers this panic, right? And in a panic, we might lose that connection, right? We might bring someone to the hospital or, like make sure they get the help they need. And if we don't feel like we're capable of providing it, right? But again, if you can just that connection, knowing that if the person is talking to you about it, there's a part of them that wants to live,
Yep.
right? There's ambivalence. So leaning into this, like what's keeping you going is a question that can kind of open the door to like, okay, what's still
Yep.
meaningful to this person? And again, you don't need to know all of these strategies, but like connecting with the person and almost managing your own panic in
Yep.
a way is going to be probably the most helpful thing, right?
Yep.
And so as you were talking, I totally forgot. I mean, it's a bit weird that I forgot about this, but I'll disclose this because I'm pretty open in general. But my son that just turned 9 the other day, right? When he was 5, he started making statements about suicide. And as parents, we're like, what? 5-year-old? Like kids, like, and for our own, like, okay, do we panic? Like, what do we do? How do we handle this? And so we actually that was the impetus to like get him to go to counseling, right? We're like, this is where we need to bring in other supports, right?
Hmm. Hmm.
But recognizing that a lot of times it came from a place of shame after he had done
Yes.
something and would make statements like, you wish you didn't have me, or you wish I wasn't in this family. And those aren't necessarily like suicidal ideation, but those are in that direction, right?
Yep.
And it's like, oh, where's the pain? What does he need? Right.
Yes.
But
Yes.
again, that panic and that if you're surprised by this, if you're blindsided by it, you might say things like, oh, don't think like that.
Yeah.
Right.
Yeah.
And it's like,
Yeah.
oh, I get where that's coming from because it's scary. And
Yeah.
so those are kind of like the don'ts, it's like try to take away or like tell them not to think like that
Yep.
because that just pushes it further down.
But the do's there too is like connect,
Hmm.
right? Take that time to connect. Like to your point about a young child saying something like that, first of all, I often inform parents like, do they even know what that actually means that they don't want to live? Right? First of
Hmm.
all, the
Hmm.
concept of that. But second of all, it's a form of communication, right? They're telling you that something's wrong, that
Hmm.
something hurts so much emotionally, or somebody hurt them so much
Hmm.
that this is their form of communication. But we haven't had the chance yet to break it down, right? So they go to this extreme response,
Hmm.
but now we have to scale it back and pick apart, okay, what led to this response? Right? What's happening right now, whether it's emotionally, something happened in the schoolyard and so on. Right. But
Hmm.
my even as a clinician, my the biggest piece for me is making that connection right away. If somebody walks in, and it's happened before, and they tell me that they've been cutting themselves and that they feel like that, you know, they want to commit suicide, right? My thing right away is connect, right? Tell me more, right? What's happening?
Yeah.
And in the back of my mind, at the same time, I'm evaluating and I'm assessing,
Hmm.
right? But I want to get them talking. I want to get them communicating in order for me to connect with
Hmm.
them
Hmm.
right away.
Yeah. And how I do that too is like I'll remind myself that if they're talking to me, that's already a protective factor, right?
Yes,
Or if it's someone
absolutely.
attending the men's group, they made the effort to attend this support group. That's already a protective factor, even if they're saying, I don't want to live anymore, right?
Yeah.
Yeah, that's part of the truth, but there's a bigger truth happening, right? So I can
Yes.
hold that and I can hang out with that, even though it's uncomfortable, right? But most people go and, right? There's an and that comes later,
Yes.
right?
Yes.
And my
Yes.
family's important, or and my kids are important, or and okay, right? So
Yeah.
then we're making space for that ambivalence again. There's like there's hope when someone is still here, right? Yeah.
Yep. And if you notice, even my train of continuing communication is tell me more. It's an open-ended question. Or not even a question, like it's an open-ended statement requesting for more information, right? I never really ask why. you know the
Hmm.
person is already in such a state where it can be chaotic, it can be confusing. So when we ask that question why, it's like there's going to be one determining factor when sometimes there isn't one determining factor,
Hmm. Yeah.
right?
No, it can be. It's multifactorial, and I think another little tip that like removing anything that might be kind of lethal, right? So
Yep.
it could be medication, making sure that medication is locked up, or making sure that like even the knives are put away. Like there's things that, as a parent, I know like I've even, helped support, children or adolescents and their parents through this where they'll go to say the emergency and then they're they're discharged. But the discharge plan is like the adult sleeps in their room for a couple of nights, right? They're not left alone and the medication is put away. So those are the
Mhm.
things that we can do like within our home. We can't stop everything from happening, but it's like we know that when it's like impulsive, if
Yep.
people don't have access to something that is, could end their life, then, they can be impulsive without endangering themselves, right?
Yep. Yep.
And,
That's
and
a
that's
that's
why
a huge one.
gun
Sorry, go
control.
ahead.
I'm going to go down
Yeah.
to, gun control and just being able to have guns locked in a cabinet with a safe, like that it delays the time that someone can access a weapon or ammunition
Yes.
can, yeah.
Well, when you going back to that point about impulsivity, right?
Hmm.
In that moment, things feel so bad, and your impulsivity just ramps up, and you do something that has such grave consequences, right? I was going to also say the other thing too is that sometimes you mentioned sort of getting into panic mode, right? We get into panic mode, and in panic mode, sometimes, well, for a lot of people, we start to talk more, right? Because we're not too sure what to do, right? We're sort of directionless, and so we just sort of ramble and ramble and ramble. Happens to the best of us. But we forget to listen, right? We forget the power of silence and to just be there. And to this point, the nonverbal cues,
Mhm.
right? Just sitting down with somebody, having a glass of water in front of you, and just even the proximity to that person, right? Helping that person feel and understand that you're there, right? We don't
Mhm.
have to do a ton of talking right now, but I'm here.
Yeah, I think when we panic, we lose that like social engagement
Hmm.
kind of part of our brain that allows us to connect. So again, we're saying this over and over again, but connect, 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 right?
Yep.
And that is hard when we're freaking out, right? So finding ways to help ourselves calm our own nervous system will allow us to then connect with someone who's in a lot of pain or struggling, right? And
Yep.
so finding our seat,
Yep.
even as therapists, right?
Yep. I remember working with a teenager, and the person didn't speak very much, but we communicated almost through paper, even though it was in person. It was actually to this day, it was one of the I think one of the most fulfilling experiences. And as you were talking, this just dawned on me, and I will never forget this. She was really, really struggling. I won't go into the details, but didn't want to talk about it. But I easily, the first time I met her, I could have probably spent 2 hours with her. And we just started to doodle, had a pencil in front of her, a piece of paper. And then from doodling came single words, right? And so the power of just being there for the person, making it as comfortable as we could be, and finding other forms of communication if needed, right? It took a while for anything to start coming out, but the power of connection is not just by words. It's just being there and listening.
And again, if you're not comfortable with intense negative emotions, this is going to be hard. It's going to be hard to sit and listen and be with someone, especially if you were raised in a way that, like, you get over it and you move on and you don't dwell on these negative thoughts. It's going to feel counterintuitive, right? But understanding that those negative thoughts just don't go away, they're going to still be there, right? And
Yeah,
shining a light on them will actually help them. So speak directly if you
yeah,
can about it. Listen more than you lecture, like you
yeah,
were saying.
yeah,
Don't argue with them about their pain, right? And
yeah,
sometimes that's hard. It's hard because they're
yeah,
only seeing part of what their life is about. And you might want to convince them that it's not all bad or that they don't need to be so worried about it. But hold
yeah,
off from that. It's better if they come to that conclusion themselves, right?
yeah. It's the power of emotional connection too. And I'll ask you this question, Dave. You don't have to answer it. I think I already know the answer, but you don't have to answer. You know, when you get into these moments with a client and you can see that the person is in pain, they're tearful. Have you ever felt yourself get emotional and your heart sort of sinks and you feel perhaps tears welling up for you as well?
For sure. Yeah. I mean, I'm human and I sometimes joke that like I try not to cry more than my clients, right? But that I'll ride the waves of what they're experiencing to some degree, right? So it is not easy to sit with someone who is, not feeling like they can live another day because their life is really bad or that feels so hard. But I think if I can reflect that back, like you're overwhelmed, you're in a lot of pain, just someone else recognizing that
Yep,
helps, right? And then we start to go to like, okay, well, I'm here for you right now. What else is needed, right? What supports do
yep,
we need to bring in place?
yep,
And we start to build that, like, okay, how do you get through this really hard time?
yep.
Right?
And I think the point of me asking that question, I feel it too. But I think for anybody supporting an individual who's struggling in that moment so much, it's not to think that you have to be quote unquote strong, right?
Mhm.
You have to be the one who doesn't tear up, who doesn't feel it, that I'm going to fix everything for you.
Mhm.
No, right? There's not necessarily any fixing in that moment, right? Going back to the idea of connecting, right? And so if you can even emotionally and empathically connect, that is extremely strong, quote unquote strong.
Well, yeah, the strength that I ascribe to, it's like, we'll get through this together. That kind of a strength. Like,
Yes.
I know this is hard. Like, but we will work at this together, whether it's a family member or whether it's a client or whether it like, just like, and that this belief that we can do this, right? This is not impossible. So I've gotten a lot more comfortable talking about this as like a natural part of living, like to think about suicide or think about not being around. Of course, whenever we're overwhelmed, that is one of the things that crosses our mind. A lot of people think about this. And so even in the men's group, it's like making that an open discussion, right? But then what are the other options? Like you can have this fantasy of like, oh, if I just wasn't here, I wouldn't have to deal with this. Of course. And
Yeah.
the fact that you are here, the fact that you are going to keep living, how do we deal with this, right? What
Yep.
are the other options to be able to deal with this pain?
hmm hmm And I think all the while too, it's also thinking, where do we go from here? Right. So what other resources do we need to put in place? So I think we've touched on, in the moment what we need to do,
Yeah.
but also as we have supported the person, okay, what safeguards do we need to put in place?
Actually, that brings up a good resource that there's an app that you can download for free. Let me just pull it up. It's called like Reminder, but it's Reminder. And in it, you can actually create like a safety plan, which a lot
Mm,
of like mental health people will know. But if it on a for the general public, a safety plan is like, when you are feeling like this, what can you do? I will do this. I will do this, and then I will do this. And it usually goes in like order of like, I can do this for myself. And then at
yep.
the bottom of that list is like, who can I call and who can I reach out to? And so those 24-hour phone numbers, those are usually
hmm
on there, right? Like if you
hmm
get to that point, you call some there, and then this is the plan. And having it on an app that you can have on your phone or on a cue card that people keep with them, right?
Yep.
Is because when you're overwhelmed, it's hard to remember to do these things, right? And
Yes.
so planning ahead, for helping someone create a bit of a plan of like dealing with overwhelm or with pain can be helpful. And again, you don't have to know how to do this. There's a lot of mental health people that this is like what they're trained in doing. So sorry, I'm laughing because Andrew's hiccuping, not because this topic is funny by any means. But yeah, so if you're looking for a resource, that's one that's free and available and easy to download, easy to find, and then also gives you some more info and some more tips on how to support someone and how to support yourself if you are going through these, having these thoughts and struggling right now.
For any clinicians and educators listening, just ensure that you do have an emergency contact so that you can make that call to let someone else know and to talk about safety measures, whether it's at home, at school, in your office. And then as a clinician, making that judgment call as to whether or not you think the person needs to go to the hospital. I've never found that to be an easy call, but sometimes a necessary one.
Yeah, I think if you work in this, like the supports that are needed, they keep the more the severity, the more the intensity and at the end, we know that like the hospital is not the best place for everyone, but it might be the only place that's, available at the time that they need it, right? And as a clinician or as a family member, you're not going to be available 24/7. You
Yep.
might be sleeping and you might have your phone on silent. So you want to make sure that the people you love or the other people have options to reach out to supports that are going to be there 24/7, right?
Yeah. Yeah.
Because you can't live in this constant being on or available for someone who's struggling. Like as much as you would want to, your
Yeah.
own your own well-being is going to suffer if that goes on for a long time. And clinicians need to learn that too in terms of having healthy boundaries and ways to,
Yes.
yeah.
Yeah. So it really is for that moment to ensure that someone is safe. To your point, nobody, well, I would say that most people don't like going to the hospital, but in that moment, it's the measure that we have to keep somebody safe. Right.
Yeah.
Yeah.
All right. Does this feel
All
like a
right.
place to end?
I think so. I think so. To be very honest, and I'll put it out there, this is a much more somber episode that even I anticipated it to be. So it's been an interesting one. I think even on an emotional level, talking about this to this extent.
Oh, I'm with you. My heart is heavier. I definitely have a lot of names and faces that are crossing my mind right now. And
Mhm.
yeah, I think it's an important topic. It's not an easy topic, right? It's not one that leaves people feeling uplifted. And, it is Friday, the weekend's coming. And yes, this episode feels a lot different than some of the other episodes for sure.
Yep. Take a deep breath if you've listened through this entire episode. I know I will be, and I'll share this too. After a challenging session or appointment, I will go lie down on the couch that I have in my office. You might have seen this in the clips, but you know, client leaves, even though I think that we're in a better place, I need to take a breather. Like I need to gather myself and think about, okay, what just happened in that appointment.
Yeah, to take care of yourself.
Yeah.
Absolutely, right? Before moving on to the next thing or yeah. And again, if this is touching you, if this is, personally impacting you, do the self-care, do reach out, get the like support that you need, right? This might be a reminder that like, oh, I thought I was okay with this, but listening to this has brought up a lot and not being alone in it. I think over and over again, this is our message on this podcast is you don't have to do this alone, right? So
Yeah.
the reason we call it taking good care is we want you to take good care of yourself and take good care of the people around you. And we're hoping that having this conversation today, it helps do that.
Yeah, well, I'm hoping that it opens up conversation, it opens up connectedness and decreases stigma.
On that note, share this with people that you think it might help and keep spreading the word. And we're going to keep doing this. We're on almost 1 year of recording. So this has been personally meaningful. Like I was going to say it's been fun because in a lot of ways it has, but today's episode feels more meaningful than fun. So
Yeah, I think personally meaningful and very meaningful as a clinician, to be very honest. Sometimes, we work so hard. I know you and I both work hard, but slowing down and having this conversation today, I think really has placed renewed meaning in the work that we do.
thanks, Andrew, and take care, everyone.
Take good care.